I'm going to talk to you about cracked teeth, something that you encounter every day, usually around amalgams. When you remove your fillings, you find them. If you have magnification, you see more of them. When I have to do a root canal, sometimes I find the crack exposed as I clean and shape, something unexpected, such as that crack, or it's very clear either to your eyes or mine, or the tooth splits on its way to see me, and of course that's an extraction. Since 2015, the American Association of Endodontists, their committee, did a survey, and they found that almost 50% of endodontists have seen an increase in cracked teeth and vertical root fractures. Of course, COVID-19 didn't help. There was an increased stress, parafunction cracked teeth left and right, people were clenching, and honestly, they still are, because I feel like the number of cracked teeth have increased since 2020, and we found an increase in males, and which is something new, as well as over 60 years old. This is a major obstacle, and we all want to know, what is that magic pill? What is the best way to manage these cracks? Because you're going to encounter it tomorrow, you're going to have to face the patient. In most of these cracks, they're asymptomatic, so really it's not even a diagnosis, it's more an observation. And usually these are teeth that have had, not always, but have had these amalgam restorations that have been replaced by composites. And as you know, frequently the cracks are found around amalgams because of the wedging effect. There are multiple causes of cracks, not only the amalgam restorations, but there's increased cuspal inclines, teeth that are the terminal teeth in the arch, bruxism, thermal cycling, unilateral mastication. So when Val puts an implant and they don't eat on one side for like a year, well, guess what happens? Everything that is unstable on the opposite side starts to wake up. And that goes for everybody who receives an implant. So there's a new vocabulary. It's not really new. It's the way we've categorized and agreed upon as how you should document what a crack is. It's a cracked tooth that happens in the coronal tooth structure. Then there's the cracks that start in the root or are observed in the root, vertical root fractures. These can go through the enamel, dentin, and even cementum. And then there's, of course, the split root. Signs of a crack. Signs that you will pick up. Teeth that have significant wear, teeth with shallow fillings or even no fillings. These are clues for me. A localized deep pocket with no other associated periodontal disease. This is a case from Dr. Choi. So this lady was an 85-year-old lady, and she complained of pain and chewing on the lower right. And I was asked to look at 4-6, and 4-6 was necrotic and had some fillings. I saw the wear, I saw the attrition, I saw the rarefying osteitis, the apical periodontitis, and then there was a 10-millimeter pocket with some vestibular swelling on the 4-6. It needed a root canal. Whether it was cracked or not was yet to be determined, right? The way you would have, as long as the tooth is restorable, it's necrotic, you do a pulpectomy, you investigate, you don't write off the tooth, right? So that tooth is destined for a root canal. But what I noticed was this tooth, 4-7, was also kind of percussion positive. It was vital. It had this vertical bone loss along the mesial, and there was a crack that was visible in the mesial marginal ridge, which correlated to the bone loss that was quite evident on the X-ray that I had taken. So that tooth, in fact, has a guarded prognosis. Now, she didn't come for treatment, but I would have investigated more. I recommended definitely a guarded prognosis because of the pre-existing bone loss in 4-7, but she came for a consult only. So those are observations. So what are the symptoms? Well, it depends on the state of the pulp. Is it reversibly inflamed, which, as you know, there's acute localized pain to pressure, release grainy food. When you chew, it hurts, but I mean, this is not an acutely inflamed pulp. There's brief pain to cold. Putting up the histological slide, I don't know if you can see it. There's been a long debate. We can't really histologically correlate to symptoms, and that's the way we've been taught, and that's the way all the studies have been presented to us over the years. But now, recently, even in Guspak's article in the Iranian Endodontic Journal, they published correlation between pain severity and the amount of inflammation, whether it's acute inflammation, severe chronic inflammation, or even coagulative necrosis. They had been able to correlate it with the symptoms. So we're getting closer to more correlation between what you see under the scope, the histological microscopy, and what you're getting from the patient. But anyways, in terms of symptoms with cracks, it all depends on how inflamed the nerve is. And of course, you treat it's one thing to treat a crack mechanically. What are you going to do to restore its strength? And then how are you going to treat it biologically? Do you need to extirpate the nerve? Do you need to do a root canal? And that goes along with your pulpal diagnosis. And so this is the current way that you have to document the condition of the nerve. Is it reversibly inflamed with symptomatic apical peritonitis? Is it irreversibly inflamed with symptomatic apical peritonitis? Is it necrotic? Is there a swelling, which you would get the coagulative necrosis? So diagnosing a cracked tooth, oftentimes I use a cotton roll to isolate which tooth is hurting. You, of course, should have a tooth sleuth in your toolbox, and you would isolate each cusp and determine where the pain is coming from. If they say they have pain to biting, sometimes they say that they've got just some sensitivity to cold, maybe to sweets. It could masquerade like a loose filling. It could masquerade as some incipient or recurrent caries. So you kind of have to be a very good investigator. You got to take your time. It's not very clear, and cracks generally take a while to become more obvious. So when they fall into your hands, it's not easy to localize it sometimes, and I appreciate that. When they come to the endodontist, it's kind of a little more obvious, and of course if it pulpally becomes more of an issue, then we know what tooth it's causing. So of course if there is a crack that's more severe, there could be more mobility. What are the other signs? You could have more than one sinus tract. That's usually a telltale sign that there is an issue. Percussion palpation sensitivity, of course the biting, the vitality testing, these are all the stuff that we do. I like to use a Michigan probe. You can use a periodontal plastic probe that's over 6 millimeters. You can remove a restoration to identify the extent of the crack. Dye staining, methylene blue is what I use. What I like to do is I like to see if I can spot a crack under a deep pocket, so I kind of spare the patient on a 3D scan if I can, because 50-50 chance I can kind of figure it out. So in this case, the gentleman that I treated years ago came back. You know, I've got pain on my upper right, tooth number 1-5. The first suspicious sign is, yeah, there's a root canal, it's not too bad, but the problem is not really localized. It's kind of sitting around the distal half of the tooth. Luckily, this is just an exostosi. There's nothing pathologic about that. But when you go inside, you've got a lingual palatal sinus tract. So where does it trace? I didn't trace it, but what I did is I pulled the gum with anesthesia and I saw a crack. I stained it. I gave him a picture. I confirmed that he needed to have the tooth taken out, and then he later saw my brother because he had an experience with him before and he wanted to have his implant done. So can we see a crack on CBCT? The short answer is really no. We judge by the patterns of bone loss that are on the teeth. The voxel, it's all what to do with the voxel size. Our voxel sizes, even in the micro CTs, which we don't use clinically, are not, the resolution is not high enough. The voxel size is not small enough to pick up a crack, which can be as small as 0.001 millimeters. So the answer is no. Don't send for a CBCT trying to get the answer that, yeah, it's cracked. So like I don't really trust the CBCT 100% because very often by looking at the pattern of bone loss, you can figure out that, yeah, there is a crack. There most likely is, but I kind of look at it from a global perspective. looking at my clinical signs and symptoms, the way that the tooth looked clinically on the radiographs, the scan. Sometimes I call the radiologist that I collaborate with. So that's how I use CBCTs with cracks, but not as like the end-all and be-all. There's a lot of artifact. You know, we're looking at teeth. Many of these teeth have had root canals, so if they've got cracked roots, you've got gutta-perca that's obstructing your view, cast posts, crowns, neighboring implants. And even with software algorithms, we're not there yet, you know. So there is a possibility that we could be overdiagnosing cracks based on the CBCT only. It's from Judy McIntyre. She had a lovely presentation, and I collaborated with her, and basically she's had some nice shots to exemplify what you should be seeing and what we're reading on a CBCT. We're reading that Mickey Mouse earlobe loss of bone that pops up along the side of the root. We're looking at coronal slices where you've got the cortical bone dipping, which shouldn't. You've got the corresponding defect. Now, this particular endodontist actually does root canals on teeth where there's a radicular crack that has even gone over the pulpal floor, and I think that's a bit dicey, you know, because there's cost involved. We're faced with the alternative of the implant. At one point, you kind of have to call it quits. But we are here to say that a lot of these teeth can still be saved, but there's kind of a fine line that we draw. At least I draw, and I wanted to share that with you. So in this case, it's from Dr. Kozovsky, rarefying osteitis involving the palatal root, the MB root. It's the infection is going along the buccal and the distal aspects of the mesiobuccal root to the coronal third. These are all bad signs, right? This is infection that's extending right to the furcation. There's a 10-millimeter pocket. Of course, it hurts. There's buccal cortical plate dehiscence. You can see this. I mean, this looks like a J-shaped lesion to me, right? I even thought that there was a broken file in there when I looked at the X-ray, but I didn't feel anything. I did the scan after I went in. I didn't see anything. I called the radio. I didn't see anything either. So we continued. I found my canals. I found the MB2 that was unfilled. See, the pattern bone loss is suggestive of either persistent endodontic pathology or a non-displaced mesiobuccal root fracture. So, you know, the word fracture is in there, so it's easy to say, oh, yeah, it's cracked. So what I do is I just don't take my time. I start, I medicate. I finished January 2021, October 2022. Of course, I obturate when the sinus tract and the probing has resolved, because that's my first clinical sign. I know that the bone is going to grow back a little bit slower, obviously. So I give them the first positive feedback. I think we're on the right track. Obturate. And then I've got a beautiful result with bone that I've grown along the furcal aspect of the MB root. So we've got a winner. This is another interesting case I did with my brother. So look at the bone loss on this young guy. He's about 25. I mean, this looks almost scary. So and this is Dr. David, this is your case. So young guy, tooth is necrotic. Of course, there's furcal bone loss, there's probing. I said, let's start a root canal. Let's see what I find, okay? So I start the root canal. I put Diapex, which you can get from Sonident. I love it. It has iodoform, it's antibacterial, additional antibacterial. It has a glycerin base, so it stays around long enough. I use it for primary pulpectomies as well. If you're doing kids, you want to throw it, it resorbs. So there it is. So I start in February, July. I saw him maybe once for a wash. Like, it was over a year that this tooth was in calcium hydroxide. I finally decided to obturate it. I had him see Dr. Val because there was a persistent furcal bone loss with a 5-millimeter pocket. So there was, and you'll see, there was a periodontal defect, and I didn't want to finish it until I verified that this tooth could have periodontal regeneration. So he said, yes, let's try, but let's wait for some more healing. Because this was a very big lesion. So look at the healing that we managed to get, but we gave this tooth time. We had a healthy patient. We had a tooth that was not cracked. But you could certainly think that it's cracked when you look at this, right? There's a lot going on with this tooth. And this is the periodontal defect that ensued. So we can't leave the tooth like that. I know there'll be a perioabscess. We've got to do something. This tooth was amenable to periodontal regeneration. So that's what Val did. So he did a surgery. He put Endogain. He had his tetracycline slurry. He did his bone grafting. And in February, there's his post-op when he did the surgery. In October, that's how it looks. In April, we've got great healing. And periapically, we've got great healing. The guy's coming for possible gingival grafting now because we couldn't do it at the same time. So gingival grafting and some other treatments and a follow-up. So this is a winner. And this is where we started. So basically, this is a nice example because it shows you that in endodontics, you need to have patience and you need to take your time. And I'm not scared of putting that calcium hydroxide and waiting because I want to give more assurance to the patient when we're dealing with a guarded tooth. And this is Diapex Plus that you can have a look at the front. So it's calcium hydroxide with iodoform. It improves the radial opacity. It's antibacterial. I always ask if you have any allergies to iodoform before I put it in. And it can be used for pulpectomy and deciduous teeth. Okay, so how should we manage these teeth with cracks? Do we monitor them? Do we restore them? Do we do root canal? Do we crown them? Do we extract them? Right? And this is kind of why you're all here, like, what do I do, right? This is a really nice study. This was a study that was, they had like 209 different private clinics that registered for this national prospective cohort, not cohort, but prospective study over 3 years. That was funded by the government, and they answered questions like which cracked teeth will get worse, when should dentists intervene, and what is the best treatment. So basically they found that 70% of the teeth that or the patients that they studied or they assessed had cracks. To enter the study, you had to have at least one posterior crack, they may or may not have to be symptomatic. So what predicts tooth fracture or crack progression? So basically a maxillary tooth with wear facets through the enamel. Again, you hear that again. Cracks detectable with an Explorer. Of course, this is a little bit more of a wider crack. Cracks on the facial surface, horizontally oriented cracks, males with more than one crack. These are all predictors, okay, where you may want to do something. So we want to start with a conservative approach. I tend to recommend, a occlusal adjustment. It's kind of a case-by-case basis. An occlusal adjustment, I recommend a night guard. There's a wedging effect between the cusps and the fossa. So there was a study in 1988 where I got these photos, which is very clear. When you have the non-functional cusp of the tooth, it's not supported, it's not cupped by its opposing tooth. So with time, with wear, as the buccal cusp of the lower molar starts to wear down, this lingual cusp gets more traumatized and eventually will crack. So then how would you adjust it? Well, you have to take the height of the lingual cusp down, and then you have to change the angulation of the non-functional cusp to make it more conducive to lateral movement so it doesn't get hit and knocked. And that's the cusp I often see cracked, is these distal lingual cusps of lower molars. In several studies have been published. In this particular study, it talks about the orthodontic band. Placing an orthodontic band is a good way to deal with a posterior tooth that has a crack. It's not as traumatic as a crown. This particular study found that only 8% of teeth that had these bands after a few months actually needed a root canal. Another study said that if you do a temporary crown, and as Gord Christensen says, to use zinc oxide eugenol cement, temporary cement for your temporary crown. He only wants to leave it a few days if you subscribe to his philosophy before replacing it with a permanent crown. So you do your temporary crown, you monitor for a few days, let the trauma of the crown preparation die down, see how the nerve settles. Is it still symptomatic? He says, chew on this pencil. Chew, 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 chew. Does it hurt? He says, give it to the assistant, have the patient chew on the pencil. If it doesn't hurt, you've already taken the final impression, finish off the crown. They'll be okay without a root canal. In this particular study, it says, let's wait a little bit, 2-3 months, kind of like the waiting game a little bit. We're dealing with a guarded tooth. They're going to invest in a crown. They've been told that there's a crack. The crack could still progress despite our attempts because we're dealing with factors out of our control. But 20% chance of having a root canal is almost the same as a tooth without a crack that needs a crown. You know, they can also undergo pulpal issues requiring root canal treatment, so it's not a bad probability. So Geraldine, Dr. Malave is not here, but Geraldine came to me. She's a lawyer, and of course she had a filling done. It hurt. She had the filling removed. She put a temporary in. It was better, but it still hurt when eating a certain way. But it was a bit better, so she decided to put the permanent filling, and the girl was still not good, so she sent her my way. So basically, of course, the filling is moderately deep, right? It's tooth number 36. That's a tooth that hurts. You've got the distal lingual cusp is positive to biting. And there's the occlusal spot on the distal lingual cusp of the tooth number 36. There's the crack. And of course, in discussions with her, I said, how's she doing? She said, you know, she's still having pain, because the recommendation was basically, you've got a tooth that's reversibly inflamed, there's a crack. I did the occlusal adjustment, said, wear your night guard, because she was not wearing her night guard, and let's just see, because she kind of sat in my chair, and she's like, I don't believe it, I just went for a filling, and you know, this is a lot, so you kind of have to judge. If you jump from like, oh, you had nothing but a filling to a crown, it's a lot to digest. So we have to take psychological steps with these people too. Yes, she needs a crown, but she wasn't ready to deal with that. And the question that the dentist asked is like, why did this crack, you tell me that this crack happened after the filling, which is possible, or was this crack before? Why didn't it hurt before I touched this tooth? And the answer is, this happens a lot. And you can open up and replace your little shallow amalgams that are chipping, and the patient's been fine for years, they chew a lot of gum, they don't wear their mouth guard, you've replaced it, made a shallow repair, and it starts to hurt, and you can't get rid of this patient. So, you know, you do your desensitization, you guys have your Gluma, your Duraflora. I have a low-level laser, which it's an amazing tool. It's like an LED light that increases your ATP, and I can do it for TMJ. I use it for desensitization. And that works, but maybe not long term. So the question is, why does it happen? I mean, the literature doesn't have a great answer for that. It's more of a clinical observation, and I agree completely. I see that. So my answer to that question is, be proactive. Take your transilluminator when you know you've got a person that's a clencher or a grinder, and take a picture of those cracks. Examine the teeth. Take an image of it before you touch the tooth and say, look, do you see the tooth has got a lot of cracks? I don't know how deep they are, because we never know how deep these cracks are. And I'm going to try to improve that. There's a filling that needs to be replaced. There's leakage. It's broken. The nerve may be affected, even though I'll do my proper steps. If the tooth doesn't want to settle down or become symptomatic, you know, you've told them ahead of time that it could be as a result of a crack. That would be my best defense. You guys have intraoral cameras. You can get your transilluminator. And just be wary of the last molars, which have the heaviest pounds of force. So those teeth are more prone to fracture. People that chew gum, grinders, flat cusps, serrated tongues. I watch them speak and I see their tongues serrated. I know they're clenching and grinding. So these are signs, as well as the masseters. I mean, I wear a night guard all the time. So basically that was the situation with Geraldine. So treatment options for cracked teeth requiring root canal treatment. This is the Iowa staging. So they came up with a way to stage what would be the prognosis if this tooth ends up being irreversibly inflamed or necrotic and needs a root canal. What do I tell the patient? Do I send them to the endodontist? Yes. We'll tell them that the prognosis is actually 92% success rate if there is no distal marginal ridge crack and there's no probing and there's no apical periodontitis. But you know, even if you drop to 84%, that ain't too bad, because you still have a tooth that is viable as long as there is no probing. As soon as you've got distal probing, then you start to have a lower prognosis. So that's kind of where I draw the line, okay? So there's lots of articles now with meta-analysis, and the summary, the short and the long of it is, there was a study in the early 2000s that said, if a tooth has a crack and you open up and it's dead, take it out, it's hopeless. And the answer to that right now is it's not necessarily hopeless. They found in this study that Olivieri, that it's not hopeless. The necrotic and the vital or the pulpitis tooth has still a good prognosis. It's about the crack depth. It's not about the pulpal status. They all said if you've got probing, the prognosis goes down, so that we know, and that's why I'm very careful to probe, and I reprobe, and I look where the crack is before I commit this tooth to a root canal. They say your prognosis goes down if you don't crown, of course. And basically, the success rate is from 85 to 90%, so it's high. Your success rate is high. But definitely, if I do a root canal, in fact, on teeth that are even not cracked, what I do is I take it out of the bite. I know this. I tell them you need to get it crowned because it's not fair to compare implants that are a finished product to a posterior tooth that doesn't get coronal support. It's not fair at this stage. You got to complete the treatment with not only a filling but with a crown. What do we do as endodontists? Well, we try to save tooth structure, right? We need to do a root canal. We've got our microscopes. We try to make our holes really small. We have our controlled memory NiTi files like Dr. Taylor discussed. We try to save our pericervicular dentin, which is at 4 millimeters above and below the CEJ, in order to provide you with a tooth that is going to last you a long time. I don't want to see them come back. Additional access cavity, which you guys have been all exposed to the conservative access cavity, which is the cavity size that basically is been found to be the best compromise. You see your canals, but you preserve your pericervical dentin, you preserve some of the root, versus the ninja prep or the truss, where you kind of work through little holes and you leave the pulpal ceiling. These things result in possible missed canals, unclean isthmuses, endodontic failure. So there is kind of a dance that we do between trying to save tooth structure and actually cleaning the tooth, right? So basically they found that the conserved endodontic access cavity, which a lot of us do, is basically the best happy compromise between saving tooth structure. Had a chance to get exposed to the M3 Pro Gold from Sonident. I really liked it, actually. Very good control memory files. They've got their path file equivalents. They work well. They've got their conservative taper, 04 taper 2025. I followed their sequence. They really handle well. They keep their shape. They don't unwind. This is a case of Dr. Choi's that I used. I finished to a 3004. I thought that was really well controlled of length. I noticed the preoperatively, what I was looking at was, okay, this tooth has got the 2 canals plus, a very defined isthmus. It's narrow. You don't want to start doing strip perforations loose. And then finally, I just wanted to point out that the woodpecker is a great motor that was created by Terauchi. He's like the rock star of the endodontic world. He lives in Japan. He's developed ultrasonic files, and he's developed his motor and a bunch of products. He's very down to earth. He has a very intuitive motor, very light, very thin head, so it has also the potential to doing your reciprocation, to go around ledges. And he came to U of T with Dr. Pune.
I included some good information that when you are encountered with those situations, you can be able to actually manage the cases with vital pulp therapy as a different treatment modality than root canal treatment, especially in cases that endodontically the cases are very challenging and difficult. There are some times that with caries there is no pulpal exposure. We're not talking about no pulpal exposure that can be managed by protective base or stepwise technique in diamond pulp capping. The topics and the items that we are including in this lecture are just about when pulpal exposure happen and different treatment modalities that can be approached. So objectives following the partial pulpotomy is we want the pulp to remain its vitality. We don't want to see any sign or symptoms regarding the pathology. No resorption, no abnormal calcification, no radiolucency in the lateral part of the tooth or in the periapical. If the tooth is immature, we want the tooth to continue its formation. As you noticed that in the beginning when I mentioned pulpal exposure, we talked about direct pulp capping and partial pulpotomy and root canal treatment, but we jumped straight to partial pulpotomy. The reason was that there are some disadvantages with direct pulp capping when immediately after exposure we place that biomaterial fillings comparing to partial pulpotomy that make partial pulpotomy superior to direct pulp capping. So we as endodontists usually prefer partial pulpotomy, and here are the reasons. First, that partial pulpotomy gives us wider space for the retention of the restoration. Second, as we showed in that picture, not just the zone immediately underlying the caries, they have inflammation. The inflammation goes a little bit further than the exposure site, so by partial pulpotomy we are removing more inflamed tissue. And it works better in larger exposures and exposures that happened, that was there for a while. And the most important is the success rate with partial pulpotomy is higher than direct pulp capping. And what's the difference between partial versus full pulpotomy? In terms of success rate, really there is no difference between these two. But partial pulpotomy is a little bit superior than full pulpotomy because by doing partial pulpotomy, the seal-rich zone of the tooth is preserved, so there is a chance that if the tooth is immature, the cervical portion can gain more thickness over time, so the potential risk for fracture will be eliminated. Because some tissue in the coronal portion is remains, so we can apply the sensibility test on the teeth on follow-up sessions. And aesthetic-wise, the tooth can have their own natural color, translucency, and they're easier to do, require less time, less effort. As I mentioned, both have very high success rate. But when we are in doubt, we prefer to go towards full pulpotomy rather than partial pulpotomy. And the reason for that is we're removing more inflamed tissue if we are not sure if we completely removed all tissues or not. So what is the best way to understand what is the pulpal status? Because we have to first know what the pulp, the inflammation level of the pulp is, and then we go for the vital pulp therapy. So the best way is direct observation of the pulp because we're going to do some diagnosis based on what we said, the chip complaint, the clinical tests, and the radiographs that we have, and then with high certainty, after we observe the pulp, we can say what the level of the inflammation is. That can be achieved by high magnification, preferably with a surgical microscope. First off, by using a high magnification, if a pulp was, by mistake, was diagnosed as a necrotic case, and we see some bleeding sites, we now know that the pulp has some vital tissues. So it can help us if we were thinking of root canal treatment. Now we can change the treatment option to vital pulp therapy. And secondly, that observation during the procedure or after we stop the bleeding after hemostasis can give us better idea of what's going on inside the pulp. Caries removal should be complete. It's not like we're leaving some affected dentin, some infected dentin. The whole amount of caries should be removed, and the reason for that, first, by leaving some caries, we are just eliminating the good visualization of the level of the inflammation of the pulp. The second reason for that is even the affected dentin, they contain microbes, and it was shown in lots of histological studies that when the caries are remained there are some chronic inflammatory cells, and they can kind of compromise the integrity of the pulp. And the third reason for that is the adhesion of the bonding resins that you're using, because the best attachment is to the sound dentin, and if the dentin is caries affected, we're going to have less microtensile bond strength. The next step is blood control or hemostasis using sodium hypochlorite. For hemostasis, the way that we are using that sodium hypochlorite is either directly we're applying the solution in the exposure site, or we can soak a small cuticle based on the exposure size to the resected pulp and apply it for 5 to 10 minutes. Next step is, after we did that blood control, is use of biocompatible material. Especially chlorotentate has lots of advantages, but there are some downsides. We mentioned in the previous slide that, for example, there is discoloration. After usage of gray MTA, the setting time is very prolonged, more than 2 hours, and the cost of MTA, which is high. That's why other versions or newer generations of calcium silicate cements have been introduced into the market to improve the setting time and also reduce that tooth discoloration. The setting time, as we mentioned, anti-angios is a good example, and for tooth discoloration, Biodentin is a good example. Before calcium silicate cements being this much widely used in vital pulp therapy, calcium hydroxide, glass ionomer cements, and resin-based materials were used as well, but the results were not as good as calcium silicate cements. As you can see, the success rate was almost as low as 43%, which is a very low success rate in clinical setting. The next step, now we place the biocompatible material. The next step is placement of the permanent restoration for the tooth in the future. Now the question may arise that if we are doing vital pulp therapy on teeth and we place the final restoration, the permanent restoration, can we crown the teeth or not? So it all depends on the situation. Sometimes we have to see do some follow-ups on patients to make sure that there is no sign and symptoms for any pathology. And at the same time, if the tooth is very much susceptible to fracture, we have to weigh these two together to see how much we have to weigh to crown the tooth. And of course, at the age of the patient, if the patient is very, very young, we have to wait more time for them to develop the development of the jaw. In summary, we said that the primary goal in vital pulp therapy is we want to create an optimal condition for the pulp to repair and preserve its vitality, and the procedural decisions as how much we should remove the pulp, because it's a very difficult decision when you open the tooth. That's why we very much emphasize on using the magnification, especially microscope, is as how much we have to go and remove the pulp to encounter the healthy pulp, because it's really based on the clinician clinical judgment. So there are lots of things that play a role in going for vital pulp therapy, the operator assessment. As we said, clinical judgment plays a very big role. What is the overall treatment plan for the patient, and patient's general and systemic health status.